Hello, and welcome to our webinar, Connecting Communities and Care Teams for Improved Population Health. This is Dr. David Nace, Chief Medical Officer of Innovaccer, and we're thrilled that we have everybody joining us. We have about 500 attendees nationally, and we have a great topic and some great panelists. But first, before we get started, I'd like to go over a few housekeeping rules. So we will be taking questions at the end and also during our polls while we're waiting for the poll results to come in. So please, throughout the webinar, as a question occurs to you, please enter your question into the chat box on the control panel, and we will be able to review those and see those, and I'll be able to access them at any point. Now, let's get started. Let me introduce our speakers for today. Ladies and gentlemen, welcome. First, I'd like to introduce Dr. Adrienne White-Faines. Dr. Fain has been a wonderful advisor for us. She's most recently been the Chief Executive Officer for the American Osteopathic Association, has a deep and long history of thinking about communities and the role they play in healthcare. Adrienne, welcome.
Thank you. Happy to be here.
Awesome. Second, we have Nathan Riggle, who is the Division Director of Analytics at MercyOne Population Health, which is a population health service organization affiliated with Common Spirit in Iowa. I should mention that as we get into some use cases, Nathan and his colleague Emily were both involved with helping Innovaccer get started, and we built our platform to help to serve them before we went national. Nathan, thanks for joining.
Yeah, thank you, Dr. Nace.
And next we have Emily Fletcher. Emily is the ambulatory care manager at MercyOne, and Emily is kind of in the trenches, working with patients, working with care teams, and working with community agencies to address these social determinants of health. We're going to learn a lot from her about the work she's done in her team today. Emily, thanks for joining.
Thank you for having me.
Awesome. All right, so let's we know that providers have, as they moved into this, difficult challenge of population health, we've been working at this for a decade. We have this emergence of value-based care, value-based payments coming from the federal government and the commercial entities doing it. But clinicians still struggle with understanding this concept of risk, particularly at a patient level. Adrienne, where have you seen this concept of thinking about risk and how one might think about it, not just from a clinical perspective, but also from a social, environmental, or economic perspective as well within communities?
Absolutely. David, these are really exciting times in medicine as we're evolving to appreciate the broader influences on health. And what you see is an evolution, not just in medical education, but in the development of care teams and even in reimbursement to appreciate how you do not recognize the patient and try to treat outcomes at the point of the exam room, but really trying to appreciate what is the full journey of the patient and what is the community and the environment and the population from which they come, because it is those influences rising 30,000 feet up or even looking upstream that have the strongest influence on both their how they present with diagnoses, but also the potential for strong outcomes and their overall wellness. So it's very exciting times as we look at population health and embrace throughout our healthcare systems the importance of aggregating as much information as possible about the patient and about the environment from which they come, as well as thinking about how they will take information and the patient experience back to the community in which they live.
Yeah, I really like this comment you made about aggregating information from a broader, more diverse sense. Emily and Nathan, how have you come in your journey at MercyOne to think about 10 years ago clinical risk and to now thinking about risk in a broader way? Let's start with you, Nathan.
Yeah, no, great question, Dr. Nace. So similar to what Adrienne alluded to, we've started our journey very focused on the typical clinical data elements that we're all familiar with. So with value-based contracts, we get a lot of great clinical data through claims. Every organization typically has an EMR, which provides lots of great clinical information. We've spent a lot of time on that kind of legacy clinical information from EMR and claims to really try to understand our patients, understand their risk, and how we can best serve them. But really, as we've evolved as a population health organization, we knew that there was other elements that we needed to pay attention to. And we started with some public sources of data that would tell us a little bit more about the patient, but really where we've had a kind of a transformative data approach is where we've actually started collecting data from our patients to have them tell us their social needs. So all of those elements have kind of been a great journey and value from the clinical data, but very excited about our new uses of social data, both publicly available and patient-reported data, which helps support the programs that Emily helps run for our community health workers.
That's awesome. And this is such great and exciting news. So Emily, as you think about this broader sense of information and factors that we've been hearing about, we often call these the social determinants of health. How important are they when taking care of patients with healthcare problems?
They are hugely important. When I started this work, I was really naive to the social factors that our patients were experiencing. I would never have guessed that we have 1 in 5 patients walking into our clinics who are having a social need, and that's their priority right now, feeding their family, getting to their job, getting food on the table, paying this month's rent. When you have those things going on in your life, how do you focus on checking your A1C? How do you focus on taking your medications correctly? So I think it's really given us the opportunity to understand, that word non-compliant that we all really hate. And I think it's really brought a new understanding to that, is that why isn't the patient following through with your guidance? It really may be a social factor that's inhibiting them from doing so. It's not what's important to them today. And so I think it's really brought in kind of a new lens for our providers that are participating to really see the total health of the patient and what's going on outside of the clinic setting.
Gosh, I know for me, when I trained in medical school, I thought all the things that I would deliver and the prescriptions I would write would take care of everything. Really chagrining to learn what we learn in the field, that only 20% of outcomes are driven by that. 80% are through these other barriers to care that we've talked about. And it sounds like these barriers to care may vary for individuals and where they live. Adrienne, I think this raises this question around, what do we mean about differences for people, right? What are the disparities that we see in healthcare, and how do we understand that? Can you share with us a little bit about your perspective about this concept of health equity and the health equity gap that certain people have?
Sure. I mean, the key is that we used to think about delivering healthcare and ending disparities by bringing about equality of access. And equality was the concept that basically if everybody should have access to all the same things. And really what we've come to find and come to learn is that this is really about health equity. And health equity is about saying that everybody deserves what they need, and that everyone's needs are different. And if you are not providing health and addressing healthcare from a health equity lens, you can be putting out access to what an individual does not necessarily need. And I think the easiest way to think about it, again, is that as you think about addressing social determinants of health, understanding an individual's needs from a health equity lens is really about understanding what each individual's hierarchy of needs is. That's the way that we thought about it a few decades ago, and now it's really about appreciating the perspective where the patient is and what's important to them. And until you break through to address what is their hierarchy of need, you are going to be blocked from moving forward on any effective care. And so it's really about delivering health equity to understand what individuals' needs are.
Now, these are amazing insights. It sounds like we're just looking at the tip of the iceberg when we're seeing patients in the clinic and looking at their chart, but we're not traditionally collecting the information that really can make a difference between two people. So let's dive into this concept of health equity. Maybe you could use this slide to illustrate the difference between two people with the same condition and how their health status may vary?
Sure. You may be familiar even with some of the work that was at the University of Connecticut that recently showed, as they look at type 2 diabetic patients, that 68% of type 2 diabetics were found to be food insecure. So you really have to stop and think about what that means in terms of the care and diagnosis and how that patient got to this point. So when you think about a healthy status of a type 2 diabetic, you want them to be able to leave the healthcare center and the medical environment and be able to walk in local parks and have access to water, understand what foods they should be eating, assume they have have access to those healthy foods, and of course that they're in a non-smoking environment. But the realities are that when that patient leaves, you cannot assume that the patient is in the environment that you may be accustomed to. It is an unconscious but very appropriate thing to do is to assume that you are walking in local parks if you yourself live in an environment where you walk out your door and there's a walking environment. It's very important to investigate and understand what it means when you say, and are you walking, to ask, and where are you walking? And is that walk an unstressful walk? Or is it a calming walk? Or is it an environment where they're not safe, or it's showing them other experiences? You also want to talk about it's not just the question of, do you have access to food? Yes, it's common to think about being in a food desert and think, how far away is the grocery store? But the other question is, what does it take to get to the grocery store that carries the healthy food? Do you have to take a bus? Do you actually have a bus card? When does your bus card run out? Or are you actually you might simply think you're taking an Uber, but do you have a credit card that allows your Uber account to work? So it's going beneath the surface to not stop at your normal assumptions and truly understand the experience and perspective of the patient. And only then can you create and give appropriate advice for outcomes and work with the patient to find solutions towards a healthier life.
Wow, that makes an awful lot of sense. And I know to do this, to address these issues of water, food, parks, like can I walk safely outside, exposure to smoke or other pollution, transportation, I mean, these are all things we normally don't ask about and the community is very aware of, and there are various agencies in the community. So I don't know, there's a number of examples here that are just tremendous. Rush University Medical Center implementing a variety of approaches, Head Start programs for low-income families for making sure their kids get good nutrition. Kaiser's done a great project, with a long-time organization called Project Access now. So there are case examples of this. Let me ask Emily and Nathan, these are new ways of thinking for clinicians, right? Do we need to train people different? How do we think different? Can we do that in-house while people are delivering care? What are the things that people need to know or think about or change in the way they do to address these issues? Nathan, let's start with you.
Yeah. Well, I'll start with the technology standpoint, and then I'll let Emily touch on the clinical piece. But I think just a basic technology point is if we find this data and information important, we need to find a good way to provide this for our providers. So I think, I don't want to speak for all of our provider engagements, but I think every time we've talked about these new concepts, they have been generally well received by providers. I think the next question then is, how can I find out this information about my patient? And I think we hear all the time, providers saying, I had no idea my patient had that need. So I think part of it is finding good ways to collect this data and provide it to the provider. And then, there might be some other opportunities to kind of build this into the care model. But, I think absolutely as we find value in this, and we personally at MercyOne have found this, if we find value in this data, providers will generally be very supportive. We just need to find good ways to provide it to them so that they can have a more meaningful engagement with their patients.
Emily, it sounds like a different role for physicians, for care managers, for care teams, and for patients.
I would agree. The thing we have found is that everyone who gets into the healthcare field wants to help patients. and we just need to give them the tools and resources to do so. We found that providers very much want to know about the socioeconomic factors of their patients that might be preventing them from following their guidelines, but they need to have the time to ask, and they don't want to ask unless they have something to help the patient. And so providing them with that care team that can wrap around the patient has made our providers much more comfortable in asking those questions, knowing that someone is going to take the next step. So we found it's really the tools and resources, and they want to do the work.
Well, this is great stuff, and we're learning a lot. Let's go ahead and turn to our audience who's here and just ask them, by asking a poll, how well is your organization doing in terms of addressing these social determinants of health? So if we could just bring the poll up, and we'll ask these 4 questions of our audience. We don't look at these issues. We've just started to look at. We're looking at them, but we're not sure what to do with this information that we collect, or we actually have begun to outreach into the community and have developed programs in order to address them. So this is all really good stuff. You know, Emily, did you do this all at once within MercyOne, or was it slow, incremental in learning, or is it a work in progress today?
Still a work in progress today, and it's definitely been incremental. We started with health coaches, I think, over 10 years ago now. Those were RN care coordinators working with patients, really foundationally in the motivational interviewing. We added social workers a couple years ago, and now we've just started adding community health workers within the past 2 years as well. So it's definitely a progression as we focused on more of the access to quality care and then more of those behavioral factors around health coaching. And now we're really following up on those socioeconomic factors and the environment the patient's living in with the community health workers. So definitely a progression.
Got it. That makes sense. And it sounds like, you know, I know the work we've done with you at Innovaccer, giving you data and information within a healthcare platform, that's been helpful in identifying some of these issues, or are you still working at that?
It has definitely been very helpful in identifying those issues. From a clinical perspective, we're able to identify those patients who have multiple providers or multiple medications, and we can really use the RN at the top of their licensure to focus on those patients. And now being able to screen the patient during their appointment, we're able to quickly identify those patients who have socioeconomic factors and connect them with a care team member that's appropriate for that work. So it's really helping us get the right patients to the right care manager.
Great. Well, let's see what the experience of our audience is. Let's go ahead and bring up the poll results. Looks like the poll is completed, and this will be very interesting. I'm just waiting for the poll to come up here. Wow, so look at all the people that are working at this. It sounds like people are along the way. You know, Adrienne, let me ask you, were you surprised by these results? What do you think about what you see here?
I'm excited by the results and not totally surprised. I think the challenge that we have right now within the U.S. healthcare system is really raising our capacity to make sure that we are checking on the effectiveness of the programs and that we're understanding that these are not one-shot deals, that you constantly have to go back to gain more perspective and work to improve on all of your activities. And I think the other thing to remember is as we look at social determinants and program development and program implementation is to also make sure that you are checking back with the users or the community to make sure that the efforts are indeed doing what you hope and intended they are doing.
That makes a lot of sense. Well, you know, we're going to go deep into this now with a case study about what they've been doing at MercyOne. It's very exciting. MercyOne is, again, as I mentioned, a population health services organization. It's, you know, one of the largest ACOs in the country, across Iowa, and many different ACOs, lots of value-based, you know, agreements in place, lots of 870 service locations, 310,000 patients. So we have a great opportunity to dive into this as a case study. Emily, as you've worked within this very large environment doing population health, embracing the data and information around social determinants of care, how have you thought about changing the way you would take care of your population and your patients? And to speak about that in the context of this slide, needing to move further upstream. Help us understand this.
Yeah, this image really resonates with the work we're doing. So the downstream is really where we started. So it's getting the patient to the right medical care. So it's having quick access to the clinicians and the clinicians providing that quality of care, having that medical home environment. And then the midstream is really where we're working right now. So that's the individual impact of a patient. So right now, when a patient comes in with a food need, we're working with that individual patient to address that food need and whatever else that is going on in that patient's life that's preventing them from being healthy. And then where we're really moving is that community impact. So that's where I feel like the social determinants of health really are, is that community level where you're impacting the whole community's well-being. So that's more things like your livable wages, your affordable housing, your walkable neighborhoods that Adrienne mentioned earlier. So that's the community level, and that really takes more policy and legislative work. And so we're moving in that direction. And I think healthcare systems across the nation are really getting engaged in those processes. But the work I've been really focused on is still really in that midstream level. We're not preventing patients necessarily from encountering a social factor, but once they've encountered one, we're working with them to hopefully resolve it. So that's where we hope to be in the future, is more of that community level.
Wow, it sounds like we all need to become upstreamists, which it seems to be a new kind of specialty when you're working in population health. Nathan, how have you thought about this from a data and analytics perspective? It sounds like you would need to have new sources of data to identify and address these issues and support Emily.
Yeah, no, absolutely. So as I mentioned in the introduction, we've been doing a lot of great analysis on our claims and EMR data and feeling like we've been able to kind of find good insights to high-risk patients, but we knew that this social information was key to include. So we started with publicly available data, zip code level data from departments of public health, et cetera, and there is some good value there. But at the end of the day, we have found that our most impactful patient engagements are very personable and very specific to the patient's needs. So while publicly available data can be very helpful, it obviously doesn't answer to what the patient is experiencing.
Go ahead. I was going to say, it sounds like you needed to go ahead and collect your own data sources.
Exactly. So what we wanted to do is we said, okay, we want to collect our own data. So we said, let's come up with a screening, and then let's identify the best patient engagement strategy that utilizes technology to collect that information. So Emily, as she's mentioned before, really was the clinical leader at our organization to kind of design, what is this screening gonna ask for? And then, how are we gonna ask for it? And as Emily did a great job kind of designing that kind of clinical architecture, I worked with Emily and some developers to design what the technology architecture looked like. So what we landed on was an iPad application that would be used with the patients as they come into the clinics, have a very simple usability standpoint, making it as accessible as possible. And that really entered in a great way to collect the data. And then the second component of it was having an efficient way to spread that data. So part of that technology architecture was to make sure after we've had a successful collection of the data, let's quickly push this to our care managers, our community health workers, and our providers who can act on this data while the patient is still in the clinic. So as they're in the clinic and they've identified needs, let's try to share that information as quickly as possible in order to be able to really strike a meaningful engagement. So that's really the technology that we went out to develop. We started with a few clinics. As we were kind of designing the clinical flow, we were starting with paper surveys, but then after collecting that data, we moved to the iPad app, and after kind of really nailing this great technology flow, we're starting to expand it to the other clinics across our network.
That sounds great, and it sounds like, as you identify and collect this data and information and share it with your clinicians, you need to develop new interventions. And there's this concept of extending the care team. And Emily, I understand you began to think about the role of community health workers. Is that correct?
That is true. Community health workers have really been the key to the success of our program. They were a new clinic role for us. We hadn't explored that previously to a couple years ago. And what they are really people who are respected in their community that are experts in navigating. So the healthcare system, the social service system, and really being that link between those two organizations. And so we've found that those community health workers that are really self-motivated, compassionate, and can make those connections are very successful in doing this work, and probably more successful than some of our clinicians who are more trained in the clinical world than they are the social service world.
That's amazing. And so this whole concept of engaging community resources with community health workers requires building alliances with community resources and building outreach processes. First of all, I want to start with Adrienne. So you've done this sort of in other spheres, working with community development. Is this an easy task? Is it a complicated task? How do you go about this?
You know, whether or not it's an easy task or complicated task really has to do with how well the healthcare institution is integrated in the community, but also how well it has established trust within the various communities. All of this engagement to gather additional information and perspective on the patients and the population is really about trust. And what we have learned very clearly is across the variety of diversity of this country and the various cultures and socioeconomic levels and communities across the country, the reality is that trust in healthcare system varies dynamically. And so until you can establish trust, you can't get the information that you need to really understand a patient's perspective and how they might respond and what they can do together to improve their health and wellness. And the beauty is that things like community workers and the key is no individual, no physician, no nurse practitioner could possibly understand every individual or every population. But community, what you do is you go to the community and welcome in the perspectives from those that are actually working with the community in a more dynamic and profound way. So finding new ways of bridging, whether it's looking at technology, whether it's talking directly to the patient, whether it's establishing better relationships and communications as a bridge between those that are in the community on a more day-to-day basis, those are all enhancement techniques to make us stronger and build our capacity to understand each other and come out with the best clinical outcomes and advice. But no, it's not always easy, but if you've established the relationships, it can be, and it's capacity that can get better and better and better. And as that does, you'll start to see the population get better and the work that we do improve as well.
No, that makes a lot of sense. And I still remember 20 years ago working in a community health clinic, having sticky notes on my computer with like addresses and names of different organizations, or having a list of community agencies. And at the very best, we might give people a reference and they may or may not be accurate anymore, or the agency may not be there, or we don't even know if they ended up going because they didn't see it as clinical. So there's a lot of education that needs to be done. And we can really, as you said, leverage technology to kind of take this to a different level. So Emily, I know you've had some sort of stories to tell about where this has been very helpful, the approach you've taken at MercyOne. Tell us about some of these stories.
Yeah, we have found that the community is really welcoming to bringing the healthcare to the table, and our community health workers have really leveraged that opportunity to go network and learn the people and actually spend time in organizations. And that has paid off above and beyond. And I just gave a couple case examples of that. One was a patient who came in identifying food and transportation needs. And what made this challenging for that patient was they had anxiety. So there was a medical condition adding a layer to that, where the patient had trouble going to food pantries. Food pantries are very busy, especially food pantries are only open certain days for certain hours. They're crowded, there's a lot of people. And without having a transportation source or their own reliable transportation, they had to rely on the bus to get there. So that was also going through a very crowded bus system with lots of people. And so that was not feasible for that patient. The community health worker was able to assist with that by actually calling the food pantry because they'd already built that relationship. They'd already toured that food pantry and known that they will make some special arrangements due to medical necessity. And so they talked to the food pantry, and they were actually able to create a special time for that patient to come outside of normal business hours so that they could comfortably use that resource. And they could use paratransit, which is a bus system option for patients who also have a medical necessity that makes the normal bus system not an option for them. So without the community health worker having relationships with other organizations and really understanding those systems, the patient probably would have been handed a food pantry and told to take the bus, and they wouldn't have done either of those things. And had the community health worker not had that relationship, they wouldn't have known that there were other options available to that patient. Another example of that was a patient who was experiencing homelessness. They were living in an area that was safe for the patient, so we didn't want to encourage them to move. We wanted them to be able to stay in that place where they did feel safe, but there wasn't any outreach organizations that served that neighborhood. And so we were kind of in a tough place with that patient. They needed access to resources, but they were not in the area where they could get that access. And so our community health worker had built a relationship with the service organization that did a lot of homelessness outreach. And they were actually able to get the patient those services and kind of made an exception to the rule. And they were able to get out to that patient that weekend and offer them food, water, and some other supplies that they needed to get through. And then the community health worker always brings it that second step. So not just filling that immediate need of getting that patient the resources they need today, but then going with them to centralized intake where they can hopefully find a more stable housing for the future. So it really just showed us that being in the community and having that relationship really helps as you try to wrap around services for these patients instead of being siloed and each just doing our piece of the puzzle.
No, that makes a lot of sense. Hey, let's check in with our audience again and see kind of where they see their responsibility in doing these sort of techniques. So let's bring up another poll and ask you as the audience, are you currently engaged with these sort of stories, with these sort of efforts in really engaging with your community resources and trying to improve health outcomes? So could be one of four things that you don't really see it as a clinical responsibility, and I kind of get that. You know, I train in medical school. I don't necessarily know that I was trained in this. Or we're considering outreach. We're cautiously testing some relationships to develop with key community relationships, sometimes a YMCA with the diabetes program, or yes, we're actively engaged with these. So while we're taking this poll, and please enter this into the poll results, there's a couple very interesting questions here. So one of the audience was interested, Emily, in how you're using community health workers. Like, are these social workers training, or are they not professionally trained? How do you think about allocating their work? What do you think about that?
Yeah, that's a great question, and one that we had to really explore because the community health worker job description really varies by organization. We've decided that lived experiences are much more important in this role than education. So we require a high school education, but beyond that, I really care more about the community health workers' self-motivation and their ability to understand the patient. So not necessarily justify a patient's decision, but really seeking to understand the why maybe they chose to spend their money on food as opposed to medications, and really seeking to understand that. I was talking to a community health worker, and one of the questions we often will ask is give them a scenario. So at a certain time towards the end of the day, a patient doesn't have food. What are you going to do? And someone might say, I would connect them to the food pantry. But a really strong community health worker is thinking, how are we going to get them to the food pantry? Do they have reliable transportation? Do they have children at home? Are the children going to go with them? If they're taking the bus, or how close is the bus stop? Are they going to be carrying their food to and from? And so that's what I really look for, is that person who seeks to understand the patient and can see all of those connections around social needs not being isolated, but all interconnected.
And it sounds like being smart, very interested, and from the community, or at least knowing the community and having good relationships is so critical to that. Well, it looks like our poll is now done. Let's go ahead and bring in the poll results. We're closing the poll now. This will be very interesting how folks are dealing with engaging with their community resources. So great story, Emily. Here we go. Very interesting, Nathan. You've been sort of working within the Mercy Health one. Are you surprised by these results?
No, I think they're, I think that with this being such a new area, I think, I steal Adrienne's line earlier, I think everything we see is exciting in this space. And no, nothing really surprises me anymore. I think it's such a learning opportunity in this new world of social data.
And I think, Adrienne, to your prior poll results comments, you're probably pleasantly surprised by these results as well.
Absolutely. I think the level of engagement and the level of commitment in these areas is outstanding. I think the other thing that people will learn is if we had the ability to have the audience show or articulate what their engagement is across their communities, you'd find that it's very customized towards that particular community. And the key is people often look for a best practice or a single solution, and really what it is navigation and patient support on this broad level can vary on various triage stages, whether on some levels we'll need social workers, some will be resource coordinators or community health workers, sometimes integrating also just the community workers who are in churches and other agencies and making sure that your institution has alerted them to understand how to best connect with you. So there's some that are very passive and others that are very active, and other levels that are fully integrated into the health system. So, you know, I would love to see behind the 64%, I bet there's some very exciting activities going on.
Absolutely. So I think going back to the stories we've heard, getting the data and information where needs are and identifying these social gaps is so important. And I know Mercy's done a great job, and we've worked with them from a data perspective, is collecting all of these different forms of data that healthcare is not used to: affordability, medication, social isolation, safety, and so on, impact healthcare. Emily, can you walk us through the kind of history of how you got involved with getting these assessment questions built into your clinics and with your healthcare workers?
Yeah, so we actually received a grant from Robert Wood Johnson Foundation and CHI Mission and Ministry Fund to start this work. And one of the first things we did was all come together to decide what questions we would ask patients. We knew we wanted them to be yes/no questions and relatively simple, because we were really just trying to use these questions to identify the right patients, and then we would take it from there with motivational interviewing. And so we decided on many questions that actually came from the Health Lead Screener. We found that tool very effective. And that's how we started. And we started on paper. And then we had the opportunity to transition to iPads, which has been amazing. It's really cut down the time that our community health workers have to spend using data entry. And so we do it two different ways. And one way is to have it at registration. When a patient registered after filling out their other intake information, they take the screening. In the other place is they do it in the clinic room. So after the rooming nurse does the intake process, they hand the screening over to the patient, ask them to take it. I'm a little partial to the in-room process because I think it elevates the importance of social determinants of health to that vitals area, as opposed to doing it at registration, where you have a little bit more things like insurance status and things like that that are less important than the vitals. So I think we really like that process. But the coolest thing that we found is that we need to catch the patients while they're in the clinic. Once they leave, it can be really challenging to reach them. And so with the app, we can actually now be notified the second a patient says they want assistance with their needs. And so that's one of the questions from Health Leads that we use. And it notifies the community health worker, so they know there's a patient in the clinic and what they've screened positive for. So they can actually go grab the patient after their visit and meet with them that day. And that has been huge.
Wow, this really closes the loop in timing and reduces the friction in getting healthcare needs assessed and addressed. This is awesome. Got some beautiful screenshots of some of the apps and survey tools that you're using here. It's really great. So what were some of the lessons learned as you began to implement these various sources of collecting data in terms of how to change the way you think about what you do in your clinics?
Yeah, when we started this work, we were working more with patients who had chronic medical conditions, and it was really more around health behavior change. So this was a new way for us to be engaging with patients. So we did a lot of plan, do, study, act cycles and tested a lot of different ideas. We went to conferences, learned from others, and we really fine-tuned how we work with patients to some things on the list below. So motivational interviewing is just as valuable in the community health world as it is with other clinical care. So really finding out what's important to the patient and helping them prioritize in that way. When we came into this work, at first we would say, oh, you screen positive for housing, utilities, and transportation. Here are some resources for that. And then we found just because a patient screened positive in those three areas does not mean that's what they want to work on today. So really trying to find out what's important to the patient and what do they want to work on today. We also saw a great presentation on social support, and that brought us back from the conference thinking, so now we know that patients would rather rely on their informal social support, so those people in their community around them, before they want to go to the more formal supports of a healthcare organization or the resources in the community. So we started asking patients about their social support. Who helps you when you need childcare? Who helps you when you run out of food? And that really helped us build rapport with the patients and also find out what was actually going on in their lives and better understand that. And then we also try to understand that the patient is the expert. Many of them have tried resources before, and they know what will work for them and what won't. So we really try to ask them what they've tried previously and what has and what hasn't worked for them. We always ask their permission because this is their conversation and they're leading it. We always try to get them to a short-term goal. So what can you work on this week? What can you do by Tuesday? And then we always arrange follow-up before leaving so that we have a next contact with the patient to close that referral loop. So that's kind of the process we've worked through, and we've really improved the number of patients that we're reaching for follow-up and those that feel like their needs have been met.
Yeah, I'm really impressed by the numbers that you've achieved in this effort. Nathan, would you like to speak about this from a data collection and where you might go with scaling this across your enterprise?
Yeah, absolutely. So as I alluded to earlier, it was really important for us to develop the clinical process first, which really makes the technology implementation stronger. So really Emily's great leadership and really identifying the best process for the clinics helped us to design a technology solution that would support that. So as we've alluded, we started as we were testing out the clinical process with paper surveys, but very quickly we were able to develop this great app that asked the questions for all of the domains we're focused on. And with that app, we're actually now able to scale that app to really any clinical setting. So as we look across our network, we're centrally located in Des Moines, Iowa, but we have large health areas across the state in both rural and other urban settings. We're starting to prioritize where we can roll this out to because we do feel like with the app, the iPad, and the data integration, we have a very scalable technology that we can transfer and scale.
No, that's really awesome. And these numbers are just so impressive. You know, we really have to look at these stories because they tell us everything. How are your patients reacting to this? How do your clinicians react to us? Emily, can you share some of these stories, these case studies around what's worked and how people react to these things?
Yeah, so the two case studies that are showing on the screen now are actually examples that came from our PDSA cycle on asking patients about their informal social supports. So we came back from a conference and really, knew that this was a great best practice and wanted to see how we could implement this in our own clinics. And so I asked a community health worker to take all the patients they worked with that week and find a way in the conversation to ask them who helps you with the things you need or who helps you with that, and just to dig in and then give their feedback. What did you find out from the patients by asking that question? And so of the patients she asked during that week, here are two very different examples of how patients responded and the information we were able to gather from that question. So the first one was a patient who was just referred for assistance to signing up for Medicaid. But in conversation, the community health worker found out that they actually needed some help with childcare assistance. And so the community health worker dug a little deeper and asked, who helped you with childcare before? And that's when she found out that it was actually a grandparent that had been helping with childcare and they had become sick and were not able to help anymore. And so through that, she was really able to build rapport with the patient and better understand where they were coming from. And that really helped them with their relationship moving forward. So not only did she now understand why the patient needed childcare assistance when they didn't previously, she now understands that the patient's also going through a difficult time in her family. So the other example is a lot different. So this patient was referred to help finding a dental provider. And so they asked, who else helps you when you need something? And that's where they learned that they actually had a case manager from a different organization, and that through that case management program, they had transportation. So in the time that she'd been talking to the patient, and this is towards the end of the conversation when she's actually about to give the patient some recommended resources, she learned that they already had some wraparound services. And that's when she was able to identify, well, great, you actually can use that transportation service to get you to the dentist. And so now we have this full closure of a loop. Before that, we would have been trying to help this patient. They would have had another case manager trying to help this patient, and no one knew what the other person was doing. And so just by asking who else helps you, she was able to find out other organizations that were working with that patient. So two very different examples of what you can find out by just asking the patient, who else helps you with the things you need?
Yeah, what you think is on the cover is not necessarily what's in the book. And it brings me back to practicing and seeing patients as they put their hand on the doorknob and turn when the visit was done, and they'd say, oh, by the way, and then that's when I'd realize I'd find out just a piece of what's under that iceberg. But I like this idea about reaching out to these agencies to work with them. Adrienne, we talked about this a little bit earlier, but if you could kind of share with us to kind of wrap these case studies up about what are the do's and don'ts of working with diverse, non-clinical, in this case, diverse partnership development.
Yeah, I think the key is very much like building the patient relationship between a patient and provider. You also, as we started in the beginning to talk about, you also have to build the bridge with the community. And because those influences will remain on the patient. How the community feels about the health center, the providers, et cetera, will definitely dramatically impact their trust with you. So the key is you want to build up those relationships. We always tell people, just as when you're learning to engage and get to know a patient, you don't want to assume or believe that you totally understand their background or where they're coming from. So that engagement is about listening, hearing, and creating tools so that you can actually have dialogue. As you've heard from Mercy, they developed their technology to create the assessment with the patient. You want to do that assessment, if you will, with the organizations as well. You want to understand what they provide, the resources, the shortcomings, but also one of the biggest mistakes we make in healthcare is assuming that patients and the population and the community actually understand our health systems and why they are there and what we are trying to accomplish. So once again, even when working with community groups, stopping and starting all encounters to say, who are you? What are your true goals? And also, here's where we are coming from as an institution, and here's what our goals are. Recognizing those goals together, you can figure out the best ways to reduce redundancy, find more effective and efficient ways of delivering resources to the patient. Recognizing that we can only create healthier communities together. We can't do it as single entities. They can't provide and keep wellness and achieve their goals as single community organizations. Some of those are the key components that I think you need to think about, and I'm sure everyone is learning about as they develop their community relationships today.
Yeah, and these are great insights, and it all kind of goes back to really identifying the issue to start working with a patient and then finding these agencies to reach out to and develop relationships. So let's go back and turn to asking our audience about whether or not they're able to get that kind of information, right? To be able to get to know what's behind the scenes with the patient that's driving these issues that they can start to develop these partnerships. So quick poll. To what extent does your organization use the social determinants of health as a way to improve patient outcomes? Either you don't have access to these new sources of information, like the way we provide data at Mercy Health, you have limited insights, you've started to gather some insights, and you've been incorporating them into your care management processes. So while we're waiting for the audience to ask that, Nathan, I've got a great question that came in from the audience to us. What are the public sources of social data that you collect, and where do you present the information that's useful? Do you present it in the EHR? Do you present it paper and pencil? What's the way that you not only collect the data, which you've talked about, but how do you then present it to the people that need to know it in their workflow?
Yeah, great question. So the data source that we consult from a public standpoint is our Iowa Department of Health website. We have a very robust data offerings in Iowa through our Department of Health. So that's generally where we start. If there's something that we can't find on that website, we go to our trusted search engine and look to see if there's any other academic or government sources. But we've had a lot of great success with our Iowa Department of Health data. In terms of sharing that information, we actually have not directly shared it to any care providers, but what we have done is started to incorporate it into some of our risk models. So if we were to give a high risk factor to a patient and we used used any of those factors. We do pass along risk information to our providers, but that publicly available social data would be built into that risk. So we try to keep the risks fairly simple because those algorithms can be complicated. So we'll educate the providers on what went into the risk, but they won't directly see the publicly available zip code data that impacted the algorithm.
Yeah, I think clinicians just want to know what to do. So I think that makes a lot of sense. Well, let's take a look at what our audience says to this poll. Pull up our poll results. But those are great insights. I think collecting the data is so critical, and then getting insights that clinicians just need to know what to do for their patients. So pulling up this poll results. Whoa, once again, Adrienne, you must be thrilled with this webinar. This is a lot of people doing a lot of work in this area that some of us weren't aware of. Nathan, does this surprise you in terms of other agencies you've worked with?
No, I think everyone's being very opportunistic and looking for abilities to use more data. So no, I think it aligns with what I've experienced.
Great. So let's turn to a little bit about the role of technology. You know, here at Innovaccer, we've used a lot of machine learning to pull data in from multiple sources, and then some artificial intelligence to present insights to people when they need to know it. Adrienne, you've been an advisor to us. Tell us what intrigued you about Innovaccer and some of the work we're doing with MercyOne.
Yeah, what's been so exciting to me about what's been going on at Innovaccer is the ability to really take AI information and data and use it proactively. And so this is a work in progress, not just with Innovaccer, but across the country as we try to, in healthcare, get much more directive and intentional about utilizing not only quantitative data, but also how do we tie in the qualitative components. Medicine as a whole has been, our research in the past has always been very focused on validating. Now we are actually working together, and Innovaccer is developing tools so that we can start to collect and utilize data in a more profound manner that's going to help us be more responsive to designing actionable care towards that's based on the needs, the true needs of the patient. So all of this work with all of the responses that we're getting, it's so exciting to think about. If we have 54 and 55% of those on the call actively engaged in social determinants, imagine where we will be even 2, 3, 4 years from now with the data and learning of these activities and being able to share to develop stronger and greater outcomes on population base. So the evolution's there and very exciting work as we start to collect the data on gender, ethnicity, geography, cultural context. Innovaccer is really developing the tools that's asking the questions across all of those various platforms. So this is exciting times.
And Nathan and Emily, I know this would go back to the very beginning of this, conversation. It's all about how do clinicians really understand the risk at a patient level. And I know we've done some work with you at Innovaccer with drilling down on this. Nathan, you've been in analytics and thinking about data for a long time. Where do you think this is today in terms of understanding this concept of risk at a patient level?
I think it's very early, but whenever insights are early, there's a lot of low-hanging fruit. So I'll speak for our organization. We do not have perfect risk models. We're relatively new in doing this analysis, but whenever something hasn't been analyzed deeply or deployed, you'll find a lot of low-hanging fruit. So we've been pretty excited about being able to find the insights through our early analysis. But once you get deeper and deeper into analysis, you find that you need more sophistication in your methods and technology. So that's what kind of pushed us towards the social determinants of health. That after we've kind of maximized our clinical models, we knew that we needed something else, and that's where the social determinants come in. And as we continue to optimize those models, that's when we need more and more support with technology and other other options with machine learning, et cetera. So still very early to us, but I think an early stage is very exciting because there's so many great insights that you haven't found before that can be quite actionable.
No, that makes a lot of sense. And it's been so great to work with you guys, to think about developing this public data source down to a zip code level and then collecting that patient information, like from an app or the pad in the waiting room that you guys have done, and then incorporating that to look at an individual patient risk very early on, but you guys are doing cutting edge work in this field, and then using that information to have your clinicians reach out, develop partnerships in the community. What a great topic. And I think it's a real call to action, I think, for us to think about population health in a very different way. Adrienne, would you like to make a last minute call to action for the audience in terms of what they should think about doing as they leave this webinar?
I think the key is don't continue to build on what you're doing. Don't be intimidated by the sometimes the concept that it is so vast and it seems like there are so many directions that you can go. The beauty is to remember that by partnering with the community actually helps enhance your ability to partner with your patient. And together, gathering data, being intentional, being innovative, we will be able to move to a point where we're not working with the patient just on the what, but we're actually working on the why. And we're also then having the data that is helping us to authentically be able to find solutions. These are very exciting times, and I'm so encouraged by what I've seen here on today's call.
That's great. And there's a reference here at the bottom right, from myth to reality. We'll actually disseminate to the audience some of our publications that we've done here at Innovaccer with groups like MercyOne around using data and information, artificial intelligence to really help leverage the key insights from social determinants of health. One last comment I would like Emily to make before we wrap up this webinar. We were able to address most of the questions, I think, during the webinar. Emily, you've been in the trenches, and I think to Nathan's point, it's been your leadership that has helped to drive a lot of this. Do you have any last words of wisdom as we look across the country and the people attending this webinar to take away from this conference?
I would just say, don't wait for grants, don't wait for funding. Try something small today with the teams you have, and then celebrate whatever you learn. I think a lot of times we wait until we have a big program or a big opportunity to jump on, but in the world of identifying health-related social needs, there is always something you can do with the team you have. So find something small, test it out, and celebrate those successes.
Great insights. Baby steps always works much better than trying to take a big leap. So I want to really thank all three of you as panelists for joining. Emily, Nathan, Adrienne, this has been wonderful, very insightful, a big learning for me, and I'm sure our audience as well. We had 580 members attend today. So I think there's a lot of folks from around the country that will take what they heard today and bring it back home. So once again, thanks a lot, and we'll all thank you going forward for these insights in helping to improve health in our communities. This concludes our webinar. Thank you very much for attending, and we will send out a copy of the webinar presentation to registrants, as well as the publication that I mentioned. Thank you all. This concludes our webinar.